Welcome back to Beyond the Prescription podcast. We are interviewing Sallie VanBlaricum, Nurse Practitioner today. Hey, Sallie.
Hi, Melissa.
How are you?
I'm good.
You are my Nurse Practitioner BFF. We go back a long way, don't we?
Yeah, back to nursing school.
Yes.
Original registered nursing school.
That's right. Down in good old Frontier Community College.
Yeah.
In Fairfield. So, for sure.
Yeah.
Sallie, thank you. I know you're busy, and I appreciate you coming in today. So, you have recently transitioned to what you do in healthcare.
Yes.
But I just want to kind of talk a little bit about basically where you're from, and then we're going to dive into your career and what the changes you've made recently. So tell me about you and hubby.
Originally from Clay County. I live in Richland County now. I started out in the healthcare field actually when I was 16. Even 15, I was a housekeeper, cook at a boarding assisted living home. And so I've been in the healthcare system a long time. And so then, let's see what else we have. My husband and I have 2 daughters.
One's quiet and one's sassy.
One's just like me and one's just like her dad, if you want to guess which is which.
So you like to help people. You started helping people at a very young age.
Yeah, I remember my grandma was diabetic, and it was so fun to go draw her insulin up and the insulin needles. I'm not sure how old we were.
Yeah.
And we would take care of her, and so I've just always loved caring for people.
That's awesome.
Yeah.
That's awesome. So you started at a young age, and then, like we said, we went to nursing school together, and then you were, didn't you do kind of a large portion of your nursing career in surgery?
Yes. I went initially to a larger hospital with nursing, and then I went back to a smaller hospital, worked a little bit in ER, and then the rest of the time in the operating room.
Nice.
Until 2021. So that would have been from basically 2009 to 2021.
So what happened in 2021?
I graduated with my master's of nursing.
Yay!
And became a nurse practitioner.
Right in the middle of COVID.
Yes, COVID. I started clinicals actually in 2020. And a week after I started clinicals, the entire world shut down. So that was hard.
Yeah.
But it was also good. I could be a help at the clinics with COVID and all the testing and stuff like that. So
for sure. So you did primary care for how long?
I did it for 2 years.
Okay. And then now you have transitioned and you are in a specialty as a nurse practitioner. What specialty are you doing?
I am in urology.
Okay. Awesome. So explain how, I guess, your years of experience in the OR, your years of experience in primary care, how are you taking those and kind of bringing those to help you in your urology patients?
Yeah, as far as surgical, it's helpful because urology is more base surgical than like nephrology. Nephrology is something completely different. So with urology, there's a lot of surgical treatment. I enjoyed working with the urologist at the time and doing the procedures, and I know the actual what the actual procedure is. It's a lot more in depth than people expect. But and then as far as primary care, I started out with you, actually. And so luckily I had you for the support, and then just having people come in there. We're in a rural area. I worked at a rural health clinic. So a lot of low income families, a lot of people can't afford their medications, trying to figure out what to treat. and things like that. So that part of it's really important to know, like your patient, like what can they afford to even do.
Yeah. And I would say like in well, primary care, but even like I'm sure you see it in urology too, but there's a whole other aspect of managing medications and like procedures and diagnostics that is controlled by insurance.
Yes. Yeah.
So we're not taught that. Like,
not at all.
Yeah.
Not with our, no.
And it changes every month, or not every month, but about every year, because the insurance companies make new contracts, whatever it may be, with the pharmaceutical companies, and that's just a headache in itself.
Yeah, especially like I see people for overactive bladder or urge incontinence, and I try to prescribe a medication, preferably one that wouldn't have side effects of like higher chance of confusion or have the side effects of constipation, dry eyes, dry mouth. Insurance doesn't usually cover the ones that would avoid that, or if they do cover it, they only cover half of it, and it's still $300 to get it a month. So
right. And then if you're living off of Social Security and you might only get $800, $900 a month to pay for your bills and your food and everything like that, you have to make a decision. A lot of patients have to make a decision of, do I buy groceries or do I buy the medication that I need? So that's extremely burdensome. And I know that you and I have kind of had the struggles of healthcare with that.
Yeah. So I get like denied like MRIs or CTs, or I have to call an insurance company and ask them and explain that this patient, I'm concerned, these are my concerns, and this is why I want to do the test, which was in my note before, but sometimes it'll go to in my favor, and then sometimes they still deny it, and I have to still go a different route. So
so whenever we talk about urology, just in case some of our listeners don't understand exactly what all that is, so like urology, what exactly is that in regards to the specialty?
Urology is basically the specialty that handles the anatomical and basically the drainage of your genitourinary system. So as far as we are I jokingly say that we're like the plumbers, like obstruction. So if you think of something that's obstructing, kidney stones, prostate, your bladder's just not working. If you have diabetes, your bladder just, is uncontrolled diabetes and it just stops functioning like it should. That would be obstruction. And then as far as anything else, we also deal with the male reproductive, having to do with the scrotum, which includes the testicles, the epididymis, deals a lot with the prostate, the most often with men. So, but that's the parts that we kind of deal with. With nephrology, it's more about the kidney function, and the kidney function not related to if it's an obstruction. If you have an obstruction, it'll most likely affect your kidney function. That's still urology, but kidney function, acute kidney failure, and things like that, that would be nephrology.
But you and nephrologist and you guys kind of work together sometimes. Like if there is an obstruction, you guys clear the stone or whatever it may be.
We make sure. I do have some patients that they coincide with, they have chronic kidney disease and they have kidney stones, so I still see them, but they still see a nephrologist, which is important. Or we have and the most confusing thing for people is really the cyst, like renal cyst. Because when you think of that, automatically a lot of times you think going to nephrology. It's actually urology. I see a lot of patients for renal cyst. And it's dependent on what it is, and we monitor size and concern of renal cell carcinoma and things like that. So that's the one that's a little bit more confusing for people.
That's kind of gray on which side to go to.
Right.
So is that something that you guys would be doing biopsies for if there is a cyst, a renal cyst, or you would send them somewhere else?
It depends on what it was. We have guidelines that you go by depending on what the cyst looks like. The look of it will give us a description of the risk factors of eventually turning into a cancer. It also gives us ideas of how to follow up. I have several patients that I do like specific CTs at their abdomen for their kidneys 6 months later, just to make sure is it growing, because you have to think the cysts can get so large they become obstructing or they become pressure on everything around them. And so you're watching for that. And as far as the renal cell, you can have like cancer you're looking for if it's, what if you start having bleeding and things like that into the kidney, and so then that's more of a surgical
issue.
Mm-hmm.
So since you kind of touched on that, what is the most common cancer that you see?
Prostate cancer, 1 out of 9 men will be diagnosed with that.
1 out of 9.
Mm-hmm. And so it's a lot more prevalent than people expect. Now, that being said, there's different types of grading on the prostate cancer, high grade versus low grade. The treatment plans are a lot different. So, but most of the time it is prostate cancer.
Okay. So what are some symptoms? If there is like a male, like what is something that you would want him to know? These are the things you need to look out for.
Yeah. Well, first, prostate cancer can be completely missed or not even realized until it's very advanced if you're not checking like PSAs. If you have a family history of prostate cancer, then checking and screening with PSAs are important, which can be done at primary care. Things that we don't want people to ignore is the blood in the urine. I had one patient that he had, some dry blood in his underwear every once in a while, had been there, wasn't really concerned about it, kind of went on, and then it was invasive prostate cancer into the urethra. So the blood, if you see blood in your urine, that's like completely not normal. You really need to be evaluated.
Okay, so you said PSA. So like whenever you say that, what does that mean? And I know you said PSA within your labs, but what is that? Explain that to our listeners.
So the PSA stands for prostate specific antigen. It is a screening test that usually done depending on your risk factors for cancer, either on every couple of years, depending on your age and things like that. What we're looking for with that number is I'm looking for basically what your baseline is, and then when it increases, then we look closer. Is there concern of cancer being there? Is there concern? Sometimes the elevation isn't always cancer, but we want to make sure it's not cancer first. So
if let's say you're a middle-aged man and with no risk factors that you know of for prostate cancer, what is the age that they need to be getting that test done?
Usually they're starting anywhere, and it depends. If you look up the different guidelines, there's, ages, but for us, anywhere around like 50 would be preferable. Now, if you have difficulty emptying your bladder, you're not feeling like you're emptying your bladder, you're getting up 3 or 4 times in the night, things like that, then getting it sooner might be helpful.
Okay. And then so if you have a male and let's say his father had prostate cancer, and what age are you going to start that screening?
So typically you would start 10 years prior to what diagnosis, but a lot of times that would be like 60 when they would get maybe diagnosed. I think it usually around like 40 or 45 even.
You would start testing.
Yeah, some of them, if it's a high risk of it, yeah.
Okay. All right. So in males, definitely you see that prostate cancer is the number one cancer that you're dealing with. And then what do you think with like females, like with cancers? What are you seeing with the females with your specialty?
Bladder cancer, which I see with males and females, the bladder cancer.
Like 50%, or is it more males or more females that you think?
Really, statistically, it's more males.
Oh.
Because the male gender actually is a risk factor. If you have
bladder cancer?
Yeah. So if you have certain risk factors, if you're a smoker greater than usually 10 years, if you're a male and you have, blood in your urine, microscopic versus like gross hematuria, or gross means you see the actual blood in your urine.
versus microscopic, which means that we don't see
You
it,
don't
but it
see
tests
it, but
positive
yeah.
on like a dip.
Urine dip, yeah.
Okay.
Yeah. So, but those are part of the risk stratification.
Okay. So I know smoking puts you at high risk for
Mm-hmm.
bladder cancer. And then are there anything else that that comes to mind that is going to put you at higher risk for bladder cancer?
Yeah. A lot of people don't know like chemical exposure, and you think, well, I don't work with chemicals every day. Well, you have to consider like oil field workers,
Okay.
extremely extremely high risk for them. Hairdressers, you're using your hair dyes and things like that. Chemicals within like a factory. You're thinking about like chemicals that we use and clean, throughout the day. I mean, it has to be exposure, but those are mostly what we're looking at. I always ask, that's my first question, what's your occupational history? Just tell me what you've done in your history.
Yeah. So like
military too.
Okay. So
Yeah.
military, just because they're
exposed, to unknown amounts of carcinogens,
Okay.
especially like Vietnam, Agent Orange, things like that.
Yeah. Okay. So whenever somebody comes in and you're asking about like occupational, like do you know anything about specifically in our community, like our rural area, that you're seeing like, well, you already said oil field. Is there another like farming?
Yeah.
Farming. Okay. Because they're going to be spraying crops and doing all that.
Yeah.
Okay. They're around a lot of that stuff.
Those are usually like, if someone comes in, these are the things that would be more of a red flag that they would automatically, I would want to get some imaging and probably look inside the bladder and see if there's an area that's bleeding or area that's concerning that needs a biopsy.
So how do you look inside the bladder?
We use a cystoscope, which most people know what a colonoscopy is. It's a similar idea, much smaller scope, and it goes through the urethra. It's a long tube with a camera on the end.
Okay.
And we look inside the bladder and look at the mucosa, and we identify anything that might need biopsy.
So can you do a biopsy on a cystoscope?
You can, but not in... Typically, you would do that in the surgery.
Not in office.
You wouldn't typically do it.
Okay, because the cystoscope's in office, and then if you see something, you would schedule like the biopsy. For the most part.
Yeah.
Okay.
Right. Because there's more to it. Because if you have, there's just so much more. Because if let's say there's a tumor or an area of concern, it's next to the ureteral orifice, which is the opening to the ureter, which is the tube that drains the kidney. If it's close to that area, then you need to, she would use dye and put up the ureter and make sure, is there anything growing up the ureter? There's more. It's just so much more extensive
than what we even realize. Yeah. Okay. So cancer, extremely important. Obviously, the takeaways I'm getting from this is, if you're a male, get those PSAs checked, right?
Yes. And if you see blood in your urine, don't ignore it.
Absolutely.
It's not normal.
Yep. And especially if you are high risk with your occupation. So
in this area, automatically, yeah.
In this area, for sure. So what, aside from cancer, what is another thing that you're primarily treating in the office?
I primarily treat what we call like lower urinary tract symptoms for men. Another term that people use is BPH, or benign prostatic hypertrophy. I don't really like that term because, is it really benign? Do you know it? Is it been, so then we just go with the term, what we call LUTs. And then incontinence, having to deal with that. Recurrent UTIs is another one that we see quite a bit. I do see some patients for erectile dysfunction. Preferably anything like that can be prevented would be preferable. So erectile dysfunction, a lot of men that come to you, it's devastating to them. It's, it has to do a lot with whether, is their blood sugars normal? Are they diabetic? Do they have coronary artery disease? Do they have high cholesterol? Do they have high blood pressure? All these things lead to erectile dysfunction. So maintaining good health is, you want to keep your erections for as long as you can be in good health. That's the biggest motivator.
Yeah.
Because medicines don't always work. They have side effects. things like that would be just preferable.
So if one of the males are listening here and they want to know how to do everything they can, with to help prevent erectile dysfunction, what are going to be some things that you would tell them?
Maintain a healthy diet, exercise, just like the normal, cardiac health. Make sure and monitor if you have like high blood pressure, your blood pressure is under control, your cholesterol. Just be more, not aggressive, but what?
Like intentional?
Intentional about your health. Yeah. Don't wait until you're 50 to go see the doctor and you're like, I haven't seen a doctor in 20 years.
Mm-hmm.
It'll catch up with you eventually. You haven't seen anybody forever, and then you're going to have to see a lot of people at once.
Yeah. So whenever you say, I want you to explain how, if you have coronary artery disease, how that can impact you from having, or make you develop erectile dysfunction.
Erectile dysfunction, how I describe it to people, is basically it has to do with hydraulics. The whole idea is you have to have blood flow that gets into your penis to create, and then the vasoconstriction that keeps the blood in there to keep the erection. Now, if someone has an uncontrolled diabetes, they have hypertension, and it's caused a lot of stress in their heart, you're not going to be able to pump enough blood or be able to pump efficiently enough to cause an erection.
Yeah. Okay. So exactly. So not only do you think like heart health as, heart preventing heart attack, but also it's going to affect everything.
Yeah.
For sure.
That's whenever, if I have a younger male come to me and their only symptoms are erectile dysfunction, then it's usually a red flag that I want to make sure maybe even be seen by cardiology. It could be a initial sign of cardiac problems.
Okay. Yeah, for sure. Didn't even think about that. So what would you say, like if someone, just like go into another topic of the bladder health and kidney health, what is something they need to do for diet, since we've kind of touched on that, diet and exercise, but how does that impact your kidney function, your bladder health, all of that?
The biggest thing is with bladder health, another risk factor for like bladder cancer is irritative symptoms. So just making sure that you don't cause a lot of irritation in the bladder. Hydration's a big thing, making sure that you stay hydrated with water, not counting coffee and tea and soda as anything.
Because what does coffee and tea and soda do to our bladder?
So coffee, tea, alcohol, acidic fruits, anything like that will cause the bladder inside of the bladder wall to become very irritated. And whenever it becomes very irritated, your bladder responds in different ways. Sometimes it'll cause you to feel like you need to empty more often. It could lead to, having an infection. If you just constantly have these irritations, then your bladder wall is going to become more prone to an infection. Generally, I try to tell people to stay away from that stuff as much as possible.
Okay, very good. So what about, since you're talking about the bladder irritants, do you see much like IC?
I don't see. It's a really difficult diagnosis because it's most likely a diagnosis. You've totally excluded all other possible options. We don't see a lot of IC. We do have people we send for that. It's really hard, especially with the bladder pain, to control. So the pain that they have is hard to treat sometimes. But
so whenever we say IC, it stands for
interstitial cystitis,
and it really impacts people's lives, right?
Yeah,
like significantly.
Yeah, it changes their whole. I can't drive that far because if I can't go to the bathroom when I need to go to the bathroom, then it's going to be irritating or it's going to be more painful and things like that.
Okay, so let's dig into. I do a lot of skin stuff. You do a lot of urology stuff. Every once in a while, our specialties meet, and there's something going on with their skin and their genital area. And give me an example of what that would be.
Could be anywhere from genital warts. Of course, that would be the first thing that would pop into anybody's mind. Something if there's some type of a lesion that will not get better, it just stays there, it's not causing any pain, you have a really big concern for penile cancer. So that needs to be evaluated immediately, most likely biopsied to make sure it's not that, because you actually, I mean, if someone has penile cancer, let's say it's advanced enough, they have to do a penectomy. They have to remove it.
Oh, wow. Okay, so do you in your guys' office do the biopsies there?
We would do it. It would be a surgical. It'd be extremely painful to do a biopsy on the penis. So it would be surgical. They would use a nerve block to try to help with pain control. It'd be a small biopsy. The other thing that we found were people that aren't circumcised, that they can't pull their foreskin back. They can't see the inside of it. We've had where, she's done surgery and sent the foreskin off for pathology. It's come back that it had cancer.
It's cancer related. Okay. So you touched on a little bit of genital warts, which I see a lot of, and that the HPV virus can kind of mutate into what type of a cancer?
Squamous cell.
Yeah.
Penile cancer. That's what... It's not always. I have had a patient that it wasn't HPV related, but it spreads fast too. It's extremely aggressive.
Right. What do you wish more primary care providers knew about urology or their patients, or how can they help assist them with issues like this?
Yeah. The biggest thing that we have that I see that would be helpful on our end would be, of course, the screening PSAs, which all the primary care in this area are fantastic. I'm very appreciative of anything that they do, especially care for the patients in our area. But they encounter some things, and patients will write them off. Like if a man has a UTI, that's not normal. Men should not get UTIs. And so there should be a little bit of a further look into it. Is it because they have like a prostatitis? Is it a cancer that's got some bacteria? There's like a lesion that you dig deeper in the guy. He's actually had blood in his urine for some time. You didn't realize it. So if you have anything like that, that just really needs to be seen by urology. And then just being more specific as far as, is it gross hematuria where they see the blood in the urine, or is it microscopic? Those make a big difference. If it's gross hematuria, it needs to be seen faster because it's either a kidney stone or something that's actively bleeding, just because they have, they did have blood in their urine or they saw it. I mean, if there's something bleeding in the bladder, you could end up having retention. So then that's dangerous for the patient. And then as far as kidney stones, I have a lot of referrals like ER or primary care or anything like that. It'll come and it'll say a UPJ stone or a UVJ stone, which are two different places. So the UPJ is the ureteral pelvic junction, and then the UVJ is the ureteral vesicular junction, which I'm probably totally saying those words wrong. But so UPJ is actually the proximal ureter right after the kidney, and the UVJ is right before the bladder.
And that's where the stones get stuck.
And that makes a big difference on treatment.
Okay.
Yeah. Okay. So it's all about like a proximal stone, which is further from the bladder, or a distal stone, which is closer to the bladder. So
on kidney stones, I remember whenever I was working with the urologist for a little bit, she was always like, no dairy in the evening time or at bedtime. Don't be going and eating some ice cream. You're going to get calcium build up in your kidneys. You're going to produce a stone. And then she would always say fresh squeezed lemonade. Yeah. Right? Not store-bought, but fresh squeezed is, how does that help?
So it's the acid that helps prevent the calcium from binding. But we usually say with a lemon, we say a quarter cup of lemon juice with water would be preferable. Which we did talk a little bit about earlier about irritants. Of course, that's, a very low amount, so that would be fine. But
So that helps keep like the stone from forming if you're high risk.
Yeah. The other thing is hydration. They need to stay make sure they're having enough hydration. I usually say if you can do 2 liters, 2.5 liters of water a day, that would be preferable.
So do you see any like specific supplement that stands out to you that's going to make you at high risk for a kidney stone?
The calcium is just a regular calcium. If you have to take calcium, we prefer to take the calcium magnesium citrate. So that doesn't cause the kidney stone or increase the risk of it as much. So, or like Tums, people that'll just like eat Tums like
all
candy.
The time.
Those are not good if you have kidney stones. And then something people don't even think about is if you have kidney stones, it's actually, if someone in your family has it, you have a high risk of developing them.
Getting them.
The other thing with like primary care, having my experience in primary care for a couple years, I actually had a situation where my sister kept calling me and telling me she had a UTI, she had blood in her urine. And of course, what do? You call your sister, who's a nurse practitioner, and try to get an antibiotic. I ended up making her come to my office, and I said, I have to do a physical exam. Because with women, you can't be for sure. Is it from the urethra? Is it from the vagina? Is it from something around that area? You can't be for sure that it's not something else. In her case, she actually had stage 3B cervical cancer that I found that she eventually had to go through treatment, radiation, chemotherapy, things like that. And it all really just started with this bladder urinary symptoms.
But she had cervical cancer, but
the blood was from the vagina.
So that's why you're saying like it's extremely important. Like if we shouldn't just you shouldn't see blood in your urine.
Right. Yeah.
And even
people just calling up and saying, I need an antibiotic. That's all I need.
Yeah.
They need to be a physical exam. So looking, and people, most people, they don't want to have a physical exam, but it's important that someone looks at your skin, looks at your vagina and things like that. They need to look at the tissue and make sure that everything's normal.
Right. And then also one important thing is with urology is if someone's having frequent symptoms of like a urinary tract infection, we really need to confirm it with the urine culture.
Right. Sometimes I do a straight cath where it's just straight from the urethra.
Yeah.
And so I know 100% sure that the bacteria that is actually coming back in the lab is from the bladder.
Yeah, and not from like the vagina or the skin or whatever it may be. Yeah. And that's one thing I guess with primary cares, and I feel like the majority of people do a good job on that. But if you're going to be taking antibiotics, we need to have a culture, right? Yeah.
Yes. Anytime, I really don't like if a patient comes in and a urine is got, if someone gets a urine and they say it's definitely a UTI, which, maybe it's like nitrite positive and things like that. But it really is important, urine cultures, because we are developing resistance to bacteria. I have a lot of patients that I'm just off the top of my head, like 10 options to try to treat a urinary tract infection, and the bacteria is resistant to 8 of them. And so the other 2 options are IV. Those are, then that's it. And you have to have IV antibiotics versus if we get a culture every time, then we know, 1, if there's starting to be a resistance, and 2, what type of bacteria. If it's a different type of bacteria every time, that's important too.
Yeah.
We shouldn't have all these different types of bacteria all the time. We should pay attention to know the details of it.
Yeah. So if you have all these different bacteria, we need to think of like what else could be going on with this patient.
Dig
for
deeper.
Sure. Yeah. So whenever we think of like skin, we always think of being resistant, like with MRSA, and MRSA's getting, stronger against most of the antibiotics we use, like you were talking about. But with the urine, what do you guys usually see that's like building resistance, like it's ESBL?
Yeah,
or
it's ESBL is the biggest culprit. Everybody, it's E. coli, ESBL, but and we are just limited. I have a few patients that there is no option to treat. We're to the point where hopefully the IV will continue to work, and then there's the other options we can try, which is kind of newer that we're doing, is installation of gentamicin into the bladder. I don't do that very often, but that is an option for people that are just recurrent UTIs that over and over. That is a possible option that we have available for that.
So talking kind of like about females a minute with, they're going to, after menopause, they're going to lose a lot of that estrogen kind of protection of everything down there and the floral health and everything. And you do see an increase of urinary tract infections as females age. And because you said, if a male's have an infection, there's something else that needs to be looked at and ruled out. But if a female's having a bladder infection, that's a lot more common, right? Yeah,
the urethra is a lot shorter, but and that's to say, as far as if you're looking, if it's just constantly, the definition of recurrent UTI would be either 3 confirmed UTIs in 1 year, 2 confirmed in 6 months. There's a lot of variations on that, but as far as anything like that, those need to be looked at.
Okay, yeah. And then, of course, cultures every time, right?
Cultures. Not reflex culture. I hate that. I don't like that.
Just a urine culture.
Yep.
Right?
You do the urinalysis, and now you need to order a urine culture.
So 2 orders. Boom, boom. So let's continue to talk a little bit about females and the estrogen production as they age. What is another thing that you see common that's maybe not necessarily related to the bladder?
Most likely women, the symptoms, like when they say recurrent UTIs, their symptoms are burning. But, is it vaginal burning? Is it actually burning with the urethra? Some symptoms we would see would be from actually what they used to call atrophic vaginitis. And then the term that I use now is the genitourinary syndrome of menopause. And basically with the lack of estrogen, the vaginal tissue in the vagina can become very atrophied, or it can actually shrink. The vaginal opening can actually become smaller to the point that it closes.
Okay.
And so
like
then,
an adhesion type thing?
Yes.
Okay.
So it's a labial fusion, and if that happens, then you're not able to actually see your urethra. So then you're actually having women that come in, they're having this incontinence or they're leaking urine and they don't know it, and then come to find out it's because their urine's in their vagina, because their vagina, the vaginal opening is so narrow, they're not able to empty their bladder correctly.
Okay, so you see that. So pretty often too. Okay, wow. And then there's things like, do you do anything with like topical estrogen, anything that?
Yeah, so we usually use estrogen, or estrace is usually what we use. That's generally for that kind of, we just want to make sure that the introitus, or the vaginal opening, is basically open enough that you can see the urethra and you're able to empty your bladder effectively.
Nice. Urological health, it has a lot to do with the entire body, and we've kind of talked about that a little bit. There's also some things that you see that are referred to you, but they're not actually necessarily related to like a bladder, issue. So give me an example of those.
Example would be someone, they're having increased urge incontinence or nocturia, where they're getting up in the nighttime. Things that would cause that would be peripheral edema. Their legs are very swollen, and when you go to sleep, you put your legs up, all that fluid drains, so then that's where you're actually getting an increase. Another would be if you're getting up at all hours of the night, could be a sign that you have sleep apnea, because your body's not waking up because it's not getting enough oxygen, but your body will wake up because it has to empty the bladder.
Okay.
So getting up so often during the night, first thing that we look at, we do usually a bladder diary and see how much is going in, how much is coming out, and how much you're going in the nighttime to see is this a risk factor. These are things that we need to look deeper into.
Yeah. Okay. Very good. So if there's anything that you want to leave for our viewers, it doesn't even have to be related to your, urinary issues.
Yeah.
Just it can be overall health, like urological related. What's something that you would leave for our listeners?
Don't be afraid to describe your symptoms or make sure that you're giving all the information. They think that they've given us all the information, or they think that they've seen someone somewhere else and then they come and see me. I may not know the information that they think I know. So make sure that the information that they're giving to that provider is what the provider understands. Does that make sense?
Yeah, so just be each time, just
make sure, be your own advocate.
Yeah.
I mean, we try as much as we can, but just be your own advocate. You know, if you have something going on and you need to dig deeper, then
yeah. And be an advocate for your own health, because maybe your provider isn't necessarily doing a culture but telling you have a urinary tract infection,
so
but you
ask
actually
questions.
don't. Yeah.
Just ask questions, not asking, not questioning the provider, questioning anybody that's ordering, but just making sure and getting all the information.
Yeah, because I mean, each person needs to help be in charge of their own health, right? Yeah. So it's totally ask the question, like, why do you think I'm having, blood in my urine, things like that. And, and always getting second opinions is always.
That's always possible.
Yeah, for sure.
Yeah.
Okay. Well, thank you for joining us today with Miss Sallie VanBlaricum, nurse practitioner, urology specialist. As you can tell, she is very educated in her field, and we are so appreciated to have her here, because we're bringing these people on here so they can help you take charge of your health. So listen to what she's saying, take the measures that if any of those are related to you, and of course, just keep thriving.